We'll be having two talks in this session about current challenges in the care and clinical management of steatotic liver disease, and our next talk will be on therapeutic management of steatotic liver disease. Our first speaker, who is going to talk about the current challenges in the care and clinical management of steatotic liver disease, is Associate Professor of Gastroenterology from Aachen University Hospital, Dr. Amna. Please join us on the stage. She is also the Vice President of Pakistan Society for the Study of Liver Diseases and member of Research Committee of World Gastroenterology Organization, and has many publications in the Index Journal. Please welcome Dr. Amna.
Thank you very much, Avakar Fatma. And Assalamu alaikum, everyone. Awaz nahi aayi. A little loud. Thank you. One more time. Assalamu alaikum. Thank you very much. So I know that listening so many people on the day 3 of the conference and just close to the lunch is very tiring. So I will just take in very few minutes. So just be with me for a few minutes, okay? So I think a lot is talked about this steatotic liver disease in the last session. And you may think that what I am going to tell you about the steatotic liver disease might be a repetition, but probably the spectacles which I will be is actually taking you to think of and see about this topic will be a little different. So thank you very much, Zishan and team, to give me this reflective topic, which is quite analytical, where I have to think what I'm putting on my slides. So ladies and gentlemen, I'll be talking about for a couple of minutes about the current challenges in the care and the clinical management of steatotic liver disease. I don't have anything to declare about it. So let's imagine a day in your OPD. So the most of us is actually see many patients, same disease with many faces. For instance, a 50-year-old male with diabetes, hypertension, and fatty liver found in ultrasound coming for the further management. A 35-year-old female with PCOS and fatty liver on ultrasound. A 35-year-old male with BMI of 21, which is not normal as per the Asian criteria. No metabolic risk factor, but a fatty liver on ultrasound. A 35-year-old male with BMI normal, no metabolic risk factor, with social drinking. Again, a question, what is a social drinking in Pakistan? That's a big question mark, but a fatty liver on ultrasound. A male or a female in 50s with diabetes, obesity, HCV infection, and a fatty liver on ultrasound. So what's happening? So fatty liver is everywhere. So how you will translate this an entire spectrum of this new nomenclature in your daily practice? Now that's the question. The information from top till you are tickling this information in your daily practice, or your every single patient is benefited by this change in nomenclature. This is what now we need to focus on. And with the same spectacles, we need to actually see what are the challenges in this domain. So what impact this change will bring? So adopting a positive criteria and incorporating the metabolic risk factor while striving to retain the existing understanding of an effort, it's going to provide us a more sophisticated attention towards alcohol consumption by dividing into a different ranges and then classifying into the different categories and creating a new subset of MET-ALD, as we've discussed about it. Providing a holistic approach for the dual etiologies. For example, MESALT with low amount of alcohol is not labeled as alcoholic liver disease. All right, and it's supporting the avoiding the stigmatization for fat and alcohol. However, South Asia is a little different. Pakistan is a little different for this very thing. You talk about fatty liver disease, you talk about obesity, and what is the response? खाते पीते घर के लोग हैं. Am I right or not? Say loudly. Am I right or not? This is what you hear every day, है ना? खाते पीते घर के लोग हैं तो खाना तो खाएंगे. So we are like well off. So fatty probably may not be a stigma for, if not everyone, but for many in Pakistan. However, yes, the alcohol is a big issue for Pakistan, and this is a kind of, that's why the people don't report how much amount of the alcohol they consume, and it remains as a kind of stigmatizing domain in this category. So this change is actually going to direct us towards the pathophysiology and treatment direction. The A step is again name something, define something, and definitely it opens up lots of door towards the diagnosis and the management and the discoveries. So maximizing the homogeneity of subgroups is again very, very important, which was lacking in case of MAFLD. So hence targeted disease screening and the drug development is the next step. Probably this nomenclature would actually help us to move. But what about the challenges? So we talk about that before coming to this Delphi techniques and the entire consensus process. So the people is actually looked at to the data. So data were analyzed and based upon some evidences, these things is actually they come up with this consensus. But again, the question comes in, how much of the previous data have been validated? How much is the new data do we have it? That leading to the question that, what about the large amount of epidemiological data from the every corner of the world that's not being analyzed and validated with the new spectacles? Is this actually remain useful or not? But this necessitates the collection of either few more studies from the every corner of the world or the validation of the existing data for the disease burden, clinical courses, long-term outcome management for this new nomenclature. So I'm glad some exercise has been done to overcome this phase probably, but few more steps to go. So the second challenge is the applicability of the diagnostic performance and cutoff of non-invasive testing under the new diagnostic criteria. So we know that the litmus data has been validated for that. The new cutoff are like being tested again for the previous NAFLD and now this is steatotic disease. Few efforts has been done, but probably I still feel this is the first step. More step has to come yet. But on the other hand, what's reassuring is whatever the data has been analyzed, re-evaluated, measured at least, they is actually correlated approximately 97 to 98% of the occasions, whatever was applied on NAFLD, it is actually applicable on MESLD as well. But definitely the other categories is actually something where we need to be a little mindful before adopting and taking each and everything on the face value. So the other challenge is actually alcohol, which is a significant risk factor that elevates the likelihood of developing a severe liver disease. Is this underestimated? So I think this is a question I'm putting to our chairs, as well as to the next speaker, as well as to the audience. Think about it. Why I'm saying that? So underscoring based among the alcohol intake, you remember for non-alcoholic fatty liver disease, there was a cutoff defined that less than 40 for females and more than 50 or 60 for males is acceptable, and that is actually, you can consider it as a non-alcoholic fatty liver disease. But the correlation between the alcohol consumption and the risk of liver disease, HCC, as well as other risk disease, we know that this is actually growing evidence that no amount of alcohol is actually safe. No amount of alcohol is safe. So based upon this fact, when even the WHO has reached to a point where it has been accepted that no amount of alcohol consumption is safe for our health, then how come a low amount of alcohol will be safe for the liver? And this is something which is actually still debatable, that keeping low amount of alcohol intake in a category of MESLD, is it acceptable or not? Or should we actually go back and just review this thing again? So again, this is something which is actually, this was about like protecting the people from taking alcohol and saving the people from alcoholic-related liver disease. So the dynamic changes in the metabolic health status and alcohol consumption pattern or the amount over the period of the time per patient may alter the diagnosis depending upon the specific time period. So this is something which actually we need to think of. This is exactly just like a child's criteria. So today a patient is sick, his bilirubin is high, his albumin is low, maybe because of a bad respiratory tract infection, he is child score C today. Tomorrow, when he'll be in a better situation, maybe after a month, he maybe actually go down into the child's B status. So what about this dynamic changes in the metabolic health status, where the people who actually could be cross-categorized at some point in time. For example, somebody is actually taking a low amount of alcohol in 2023, but will be taking a large amount of alcohol in 2025. So will we label that patient as MESLD, or will we label this patient as MET-ALD or ALD, something like that? So I think this dynamic changes and crossover will come in our way when we will be following this nomenclature. So the impact on the potential disease modifying agents, how this is going to address, for example, the category of other diseases, these things will be addressed. But one question is about, again, for the lean fatty liver disease over here. Bilal has addressed about this point, but this is I think, that even the lean fatty liver disease patients or lean steatotic patients will is actually into two categories: the people with metabolic factor and the people will be without metabolic factors. So how you will address this category in this dynamic with this overlap type of phenomena? I think this is actually we need to think a little bit more. So the other confounders might actually need to address at some point in time, and the major role will be coming for the nutrition and the dietary cultures. And I think the dietary culture is one thing which is actually associated with obesity as well, especially maybe the junk food and all, and which is again one major risk factor for the steatotic liver disease. So I think this is a challenge how these confounding factor will be addressed. So now coming to you, that this nomenclature will bring another challenge for us. So the most of the FDA's approvals are based upon the improvement in NASH, based upon the biopsy, based upon their ALT levels, non-invasive markers. So there are set up criteria based on which the studies is being approved. So now what will be the future? So will they be based on MASH improvement? How we will define as a MASH improvement? What will be the new criteria or a gold standard or a target outcome for with this nomenclature for the drug approvals? Maybe we can listen from Dr. Bilal. Maybe he can touch on this point in his next presentation. The exclusion process can be avoided, and in the diagnosis can be made based upon the hepatic steatosis in the presence or absence of a cardiometabolic risk factor. This is something which is like really wonderful, making your life very easy. Look at the cardiometabolic risk factor, and then you can quickly divide them into MESLD and all, which actually reduces the burden on the clinical practice. But you may agree with me that there is a little variability in the clinical practice in the real life. For instance, people still diagnose fatty liver disease, the older terminology I'm using, based on कि जी diabetic है, obesity है, dyslipidemia है, ultrasound के ऊपर fatty liver आ गया है, B और C नहीं है, which is one of the most common reason for fatty liver for liver disease in Pakistan. And based on that, considering the high risk factors, absence of other risk factors or symptoms for any other liver disease, they say this is a fatty liver disease. They don't go for the further workup. But there are a set of physicians, gastroenterologists, who would like to rule out other causes, for example, autoimmune hepatitis in case of female or a high-risk category. And based on that, they will be ruling out other diseases, and then they will reach to a conclusion, yes, with the diagnosis of exclusion, this is a steatotic liver disease or fatty liver disease. But now, if you will follow this exclusion type of process, then probably there will be a cost incurred for exclusion, which we will be saving, but then when we will be categorized them into the different categories, there will be a cost incurred. Increasing awareness to the non-GI physician, this is a big mission. Probably the GI society have to handle for it, and that's why probably they're very excited about this nomenclature and spreading the word in the non-GI communities as well. The cost of identification and the treatment is going to be high for many countries, for example, like Pakistan. And what extra are we going to offer in terms of treatment in 2023? I think what's next after naming? What's next after naming is something probably which is a huge challenge, despite the fact that so many drug trials are going on and we are having new options available to treat such patient. But still, just like hepatitis C, there is no groundbreaking medicine is available at the moment where you can treat the people for 6 months or 3 months or maybe an year and the fatty liver will disappear. So probably this type of miraculous medications we don't have at the moment, but definitely we can hope for the best. Ladies and gentlemen, lots of miles is still to go. But at least, as I said, every journey starts with the first step. Renaming, naming, better categorization is actually clears the fog and is actually give you a clear direction, and probably this new nomenclature is a part of the same effort, and definitely the more coordinated efforts are needed to continue our journey in this regard. Now I'll bring your attention towards our own Pakistan. So we can endorse, we can adopt, but is this an evidence-based endorsement? Is this an evidence-based adoptment? So leaving the question for you, this is our generation. And this is what we have gifted to them. So we can talk about all of this, but probably we also need to come and join hand with each other and do something to prevent this our generation, at least provide them a healthy lifestyle, discourage unhealthy lifestyle, and giving an obesity to the children and giving a steatotic or a fatty liver disease in the future. And what about, as Sonia, I'm glad Sonia talked about it, that some evidence-based data, from where it will be coming. So we have a couple of studies from our center, a population-based study where 1,400 people were actually low risk from the community, were screened, and the disturbing thing was like approximately 70% people were actually having some degree of fatty liver disease, despite the fact that they were either non-diabetic or they were diabetic. However, the proportion was pretty high in patients who has diabetes as compared to the people who didn't have even impaired glucose tolerance or no diabetes. With that, I think South Asia is a little different than Asia. So the most of the data of South Asia, which comes, that's tiny, but that comes from our neighbors. Doesn't come from Pakistan. So our culture is a little different. Our lifestyle is a little different. So probably what we need to collaborate with each other is knowing ourselves, what our patient exactly are facing. And here's an initiative, and you all are welcome to join and collaborate, and let's move one step forward in an efforts to make an evidence-based, what should I say, endorsement or adaptation of anything, and let's contribute the data from the South Asian population in the same domain, which will actually ultimately help our patient. I thank you all for your kind listening. Thank you very much.